So it is my pleasure to be here today. And I would just say that this was a very interesting topic. I've never talked about dialysis for primary physicians. Typically, when we have any discussions about dialysis or transplant, it is within the nephrologist, or maybe sometimes you can do some educations for the patients, but it was very interesting. So I welcome the opportunity to talk about dialysis for the family physicians. And I would love your feedback so that, if I've not covered the material to your expectations, then I can do a better job, because I can see that this topic being asked again, at least in the Brampton area. So the objectives of today's talk is what does a family physician needs to know about dialysis, and what to know about transplant for end-stage renal disease patients. I just want to start with, when we talk about dialysis, when do we start dialysis? So there are certain indications when we do dialysis, and those are if the patient has resistant hyperkalemia. So you have done your routine management with KX late shifting, and then it is resistant, then in that situation you would consider dialysis. The other things would be refractory fluid overload, so your typical diuretic regimen is failing. In that situation you would consider dialysis. If the patient is having uremic pericarditis, that would be an indication. And if the patient is exhibiting some symptoms of uremia, such as nausea, not feeling well, weight loss, in that situation you would be considering dialysis. So when a patient is approaching end-stage renal disease, what are the options the patient should have or we should be discussing? So the things which we should keep in mind is that the patient can go for hemodialysis. They can pick peritoneal dialysis. Transplant is always a good option, but I would like to take a moment to highlight that there is another approach, which is the conservative care, which we are not presenting to our patients as well as we should be doing. And there has been a lot of focus from the Ontario Renal Network to educate patients about this modality as well. So we'll talk about this a little bit later in the presentation. So in terms of dialysis, you guys are familiar with hemodialysis and peritoneal dialysis. Hemodialysis can be done in the routine conventional method, where typically the patient comes to a dialysis center 3 times a week, and we do dialysis for about 3 to 4 hours. The other approach would be home hemodialysis. So in the home hemodialysis, basically we train the patients or their family members. We supply them with the equipment. They need some modification in their house. Some plumbing and electrical work needs to be done. We provide them with the dialysis machine. The training takes about 6 weeks, and then they can do dialysis at home. The advantage of doing home hemodialysis is that you can pick your own schedule. So you're not tied to a schedule to the hospital. So if you want to do dialysis in the morning, you can do that. If you want to do it in the evening, you can do that. And you have the flexibility. So if you are going away and you want to do dialysis, say, only 5 times a week, you can do that. So it gives a lot of autonomy to the patient to pick their schedule based on their lifestyle. Go ahead, sir.
I don't know if you're going to ask this because you're probably going to go on, but with hemodialysis, I have somebody who's got the AV fistula, and I swear to God, it's been 6 years, and her kidneys have been stable. So she hasn't gone to dialysis, but the vein is larger. It's become aneurysmal. It's larger than the person's upper arm. How common is that? And do they ever burst?
Yes. So
I swear, the vein is bigger than the arm.
I can see the challenge which you're facing in your practice, taking care of this kind of a patient. So it is not that common that the patient who is not using or not on dialysis, not using the fistula, has such robust aneurysms, but they do happen, typically more when you are using them, because when you are using the fistula, these patients are getting the fistula punctured 3 times a week. So that makes the vein weak.
Do they ever burst?
Yes. So it's rare. It can burst, but again, we monitor these patients on dialysis with our vascular access team so that that situation never happens. So in your situation, the patient probably needs to follow up with their vascular surgeon. Because I'm pretty sure that since the patient is not on dialysis, nobody's looking after that. So moving on to peritoneal dialysis. So the peritoneal dialysis is when we do dialysis at home with the PD machine, and we're going to go into details as well. This can happen in two formats. One is a continuous modality where the patient is doing peritoneal dialysis at night with the machine, and then during the day as well, the belly is filled with the water, which would be the dialysate. Or depending upon the situation, we can do only intermittent peritoneal dialysis, which is done at the night, and during the day, the belly is empty, which we called that the belly is dry. So what does the hemodialysis looks like? So basically in a hemodialysis, you have a patient, you have a machine, and in a simple terms, we are taking the blood out of the patient, the blood which is now not pure or has toxins, and with the help of the machine, we are cleaning it, and then we are putting it back into the patient's body. So in simple terms, that is what hemodialysis is. So what happens is that we have a dialyzer. So in the dialyzer, we have a counter current mechanism like we have in the kidneys. So there is a blood coming from one side. So in this case, the blood is coming from the top, and the dialysate is coming from below. So the blood is going in this direction, dialysate is going from opposite direction, and there is a semi-permeable membrane, which are these fibers of the dialyzer. And the waste, which is in the blood, with diffusion, is going into the dialysate. So basically, all the urea, creatinine, potassium, whatever we want to remove, the concentration of the particles which is high in the blood, because of the diffusion, and in certain situations, convection, it comes into the dialysate, and then the blood, which is now more pure, is returned back to the patient's body. So I'm glad you brought the topic about access. So access is a very important piece for the patient's journey during the end-stage renal disease. It is basically their lifeline. So patient can have three forms of access. One is AV fistula, another one is AV graft, and the third one is catheter. And I'm going to share with you what are the advantages and disadvantages of each kind. Typically, grafts are not that common because in Canada, we have either fistula or a catheter as primary form of access. But if you will go to other countries, specifically US, they have a high utilizations of a graft, which is basically a plastic Gore-Tex tube which connects the artery and the vein. So talking about AV fistula, so as you can see, there is an artery. It could be a radial artery or a brachial artery. So you can have a lower arm fistula or an upper arm fistula. And the fistula is a connection between artery and the vein. Can anybody tell me why we need to have this connection? So the reason to have this connection is that in a normal human person, the veins are not as robust, sturdy, thick, that they can withstand the trauma of getting the needles put into the vein 3 times a week continuously. So we want the veins to become thicker and bigger. So thicker so that you can poke them again and again and they can still survive, and bigger because the dialysis nurses can then easily put the needles in. Because if the veins are small, then they can make mistake and the needle cannot go into the right place. So that's why the surgeons does this, it's not a relatively complicated surgery. It's a relatively easy, straightforward surgery for the vascular surgeons. The patients go home the same day, and then they get this connection made. It takes about a few weeks to maybe a couple of months for this fistula to get matured, and then it is ready to be used by a dialysis unit. This is a same thing. This is a AV graft, but this is a artificial Gore-Tex tube where the connection is between the artery and the vein. The blood is coming from the artery, going into the loop, and going back into the vein. And the dialysis nurses would put needles here and here so that there is an outlet for the blood to be sucked out of the body, cleaned, and then an inlet to put the blood back into the patient's body. This third form of access, which you may have seen quite commonly in your practice, is an catheter. So sometimes you use the term permacath, meaning permanent catheter. It is a misnomer because nothing is permanent. This can come out. This is not a preferred form of access for majority of patients. In some patients where we think that the patients may have a short lifespan or they have exhausted their options for an AV fistula, this may be a reasonable choice. But patients like it because they don't have to feel the pain of getting needles stuck into their fistula 3 times a week. But it is convenient and easy for them, but it has a lot of problems which we're going to discuss. So this is a real example of a patient where you can see that there are 2 needles. So they are color-coded. This is the arterial side, and this is the venous side. So like I mentioned, so basically there is a connection between the artery and the vein. It is end-to-side connection. The advantages of AV fistula is that the rate or the risk of the infection is low in comparison to graft and the catheters. The other advantage is that you have the surgery in the beginning, and once it is ready and mature, then the maintenance is less, which means that the patients will have less procedures down the line. So as you are talking to your patients in your practice, and if this topic comes up, sometimes they do value the family doctor's opinion, even on things which may not be directly under your domain. So I would encourage that if you can give them the message that if you have to pick an access, then AV fistula would be the right kind of an access, and catheters would be probably something which they should avoid. So that's why it is the goal for most dialysis patients. Something which you should be mindful is that it takes a little bit long to mature. If you put the catheter, you can use it the same day. So it's kind of an instant situation that you put the catheter, you use it. For AV fistula, you have to plan. So as the person is approaching end-stage renal disease, you get the fistula, get the vein mapping done, see the surgeon, get the surgery, and then, so I typically tell the patients that, we put the fistula about 6 months before we anticipate that they will be needing dialysis. So just to come back to your patient, it is rare. Typically, we are careful when we are putting the fistula, but sometimes we have situations where the patient does not progress. Good for the patient, but they are still stuck with the fistula. AV graft, like I mentioned, is a plastic tube, works similarly like an AV fistula. So the advantages are that you can use it quickly, within weeks, rather than months as compared to AV fistula. The downside is that increased risk of infections and more procedures. They are more prone to clot because, as you can imagine, that this is not a natural body vein. It is an artificial structure, so it leads to thrombosis, it leads to stenosis, so high risk of clotting and high risk of repeat procedures down the line. Coming to dialysis catheters. So dialysis catheters, like we talked, are again an artificial tube which goes into the central vein. So typically in the internal jugular vein, preferably on the right side because the line is more straight, so less chance of stenosis, but you will see that the patients will have wherever they can get in. The downside is that the risk of infection is quite high. So on an average, a patient who has dialysis catheter, you can expect catheter-related infection about once every 6 months or so. It's an average, so some patients you may see, they will say, I have never had any issues for 2 years, but we also have patients who are having these infections every month. So on an average, once every 6 months. The other problem is sometimes these catheters don't work because they get clotted. The thing which we worry the most with these catheters is that it can lead to central vein stenosis. Since it is going and sitting into your big SVC, so the tip is actually inside the right, right atrium. So you can imagine that the risk of infection seeding the valves is high because of bacteremia, and the risk of central vein stenosis is good. Once you have a central vein stenosis, there is no turning back. There are no good options to treat. And the patient loses the option of getting the access in the future, because once that vein is blocked, even if you create a fistula in the arm, it's not going to work. So that's why we put a lot of emphasis on educating the patients that why go for the fistula first and keep the catheters as the last option. Some tips to keep in mind for an end-stage renal disease patient is save their arms, because we want their veins to be preserved to create an AV fistula. So if a person is right-handed, we want to save their left arm for dialysis access, which means that avoid doing any blood pressure measurements on the non-dominant hand, avoid any blood draws on the non-dominant hand, and educate the patients that, when they're in the hospital, tell the nurses that this arm you cannot use. So if you have to use anything for blood drawing or IV medications, use the dominant arm. The peritoneal dialysis is a very simple concept. Basically, we are using a dialysate, and we are putting that fluid in the patient's peritoneal cavity. We'll let the fluid sit there for some time so that the diffusion can happen and the waste from the bloodstream can come into the fluid, and then this fluid is drained. So it can be done either with the help of a machine, which we call cycler, or the patient can do it manually with the help of gravity. So in this situation, the bag is hung. By the gravity, the fluid goes into the belly. It sits there for, say, 4 hours. It does the cleaning, and then you put the bag on the floor, and all the fluid from the abdominal cavity will drain out. So you do this multiple times during the day, and that helps clean the blood. We have already discussed, I'm not going to go into detail into this. I think we don't have the time. I had a good video to show actually how the machine looks like, what is the experience for the patient going through. You won't be able to appreciate, what they have to do on a daily basis, because we find it difficult even to go for a blood draw, once every 3 months, and some of our patients, they have to do it on a daily basis. So it is quite overwhelming and rewarding experience, and you appreciate the things the patients are going through. I want to bring attention for all you folks is about the residual renal function. So what that means is that even though the kidneys are working, say, 4%, 5%, their GFR is 4, 5, this little bit of kidney function is very important. This study basically shows that the patients who have urine output versus patients who don't have urine output and who are on dialysis, patients who have urine output have lower mortality. Studies have shown again and again that patients who continue to make even a little bit of urine, even if it is 500 ml a day, have less dietary restrictions. So we don't have to tell them, don't eat potassium and phosphate and things like that. They have better quality of life, and their overall survival is better. So don't presume that if the patient is on dialysis, we don't have to use the techniques which we do to avoid or preserve their residual renal function. So, be mindful that the contrast is still a problem. So even if the patient is on dialysis, just don't get the CT scan with the contrast. Be mindful that preserving these renal function is very, very important for the patient. So in last few minutes, I want to share the transplant process, because this is the modality which actually gives the best quality of life and best survival to the patient. So this is the goal. So dialysis is the bridge, but this is the ultimate goal for our patients. Some of the patients may not be eligible for transplant, but whosoever is, this is what we are striving for. So in a kidney transplant, basically the transplant is done in the iliac veins. So if you see the patient, they will have the kidney either in the right lower quadrant or the left lower quadrant. This is where the new kidney is placed. This is some data from St. Michael's Hospital. So we partner with St. Michael's and UHN, and in a year they are doing about 150 kidney transplants. Any center to have a good success, they should be doing at least 100 transplants a year to maintain their expertise. So when a patient comes in our dialysis unit or even in our MCKC, which is the pre-dialysis clinic, we talk about transplant. So we see if the patient is an appropriate candidate. We prepare the recipient by checking if they have any conditions which will preclude them from transplant. These patients go through an extensive workup, and you may have seen letters from your nephrologist or dialysis unit. We need a fit test, we need PPD testing and colonoscopy and whatnot. It is because we want to exclude any possibility of malignancy in these patients before we send them for transplant, because once they are on anti-rejection medications, if the patient has an underlying malignancy, that will make the situation worse. So these patients go through a very, very extensive screening. Some of the contraindications to transplant: if the patient has active malignancy, if their heart and lung would not allow them to be a good surgical candidate, severe obesity, severe mental illness, drug abuse, and non-compliance. So when you're seeing these patients in your practice, if they're non-compliant and they're interested in transplant, tell them that you need to listen to your physicians, your nurses, and take your medication and show up for your dialysis. Otherwise, they will lose the opportunity of getting the transplant. You must be asked by your patients, what is the wait time for kidney transplant? So it depends upon the blood group type. So blood group A have relatively shorter shorter transplant wait times, 4 to 5 years. Blood group B and O, the wait time is around 7 to 8 years. So, it makes quite difficult for some of our patients to wait that long. So in these situations, what we can do is we can encourage them if they have a donor, because if you have a donor, then you don't have to wait for these many years. The live kidney donation gets completed within 6 months to 1 year, depending upon how quickly the patient and the donor does the testing. I also wanted to bring your attention to something which we call extended criteria donors. So I want to share with you what does that mean. So the extended criteria donor are the donors who are, I would say, not in the perfect health, but their kidneys are still good enough to be used for a kidney transplant. So the definition is all the donors who are 60 years of age or older are considered expanded criteria donors. If they are between age group 50 to 59, if the donor had died from stroke or CVA, if the donor had a medical history of hypertension, or if the donor's most recent creatinine clearance was 60 to 80. So you can say that these are a little bit suboptimal kidneys. So why would somebody use it? Because the wait time is 7 to 8 years, versus here it could be less than half. So if your patient is, say, for example, 70-year-old, rather than waiting him for 8 years when he may not be a transplant candidate because his health may be different. From the cardiovascular standpoint, he may not be eligible for transplant. In those situations, doing the transplant early, even with a suboptimal kidney, may be a better situation rather than not getting a transplant at all. So what are the steps which our programs have done to increase the organ supply is the St. Michael's and the UHN does the paired exchange, which means that if you have a donor and your donor is not compatible for your patient, and similarly there is another family where there is the same problem, they can pair, so they can exchange the kidneys. So my donor can give the kidney to someone else, and someone else donor gives the kidney to me. And this allows kidneys not to go wasted. This allows more donation to happen. And then we talked about the extended criteria donor. With the current advancement, even if the blood group type is not matching, you can still do the transplant. So you have special protocols. They may have to go through more intense immunosuppression regimen, but the blood group is not a problem. You can still do between A and B, A, B, and B. What is the success rate of transplant? So 1 year success rate is 95% for living and 85% for deceased donor, and 5 year success rate is 85 and 70% respectively. So overall, transplant gives good value to the patients, and they have better quality of life. They are not stuck to a dialysis, and their survival is better. So this would be the preferred approach. And sometimes patients have some myths or misconceptions that transplant is not safe. There may be problems, but my purpose was to share with you that it is a very effective and safe treatment option. So this is my last slide. So like I mentioned that I wanted to cover about conservative care. So like anything in life, nothing is perfect and nothing is absolute. But one thing which we know is whosoever has come in this world has to go one day. And we can decide what we want our end to look like. When you discuss with patients, and you ask the question, do you want more days in your life, or whether you want whatever the life you have to be more productive and meaningful? Many times you get the response back that, whatever I wanted to achieve in life, I have achieved that. I don't want to go through the struggle of dialysis, making multiple visits, or spending my last days in the hospital. So there has been a lot of focus on conservative care, and this is backed by a lot of evidence that patients who are elderly, age 80 or plus, and have multiple comorbidities, in those situations doing dialysis versus not doing dialysis, on an average, patients don't live longer, but their quality of life is quite compromised. So there's a lot of focus with the ORN, and you may see, patients being talked or discussed about this option. So just keep in mind that this is not a bad option. This makes the right sense for the right patient. It is not for everyone, but patients where we anticipate that their lifespan would be quite limited, rather than putting them on dialysis, aiming for a more conservative approach would be the right thing to do. I think with that, I have concluded my presentation, and I'm happy to take questions.
So you gave criteria for starting dialysis or starting the process of dialysis. So in your experience and from others what's the highest creatinine clearance that you have as a group, as nephrologists, starting somebody on dialysis?
Yeah, so that's a very good...
Because I always think about stage 5, 15 and under.
Yeah.
So
Yeah.
at what level have you...
That is a very good question, and there has been quite a bit of studies which have been done comparing whether we should be starting the dialysis early or whether we should be starting the dialysis late. So when I mean early, I'm saying GFR around 12 to 15, and when I'm saying late, I'm meaning when the GFR is 6 to 8 in that range. So studies have shown whether you start early or late, it does not make any difference in terms of the overall health or longevity of the patient. So in our practice at William Osler, as compared to other centers in Ontario, we start dialysis quite late. So typically our patients start dialysis on an average GFR of around 8. I know many centers start dialysis maybe around 10 and 12, but it would be rare to start dialysis more than 15 in certain situations, such as when a patient has, say, a cardiorenal syndrome, and you cannot get rid of their volume with the diuretics, and the patient is having frequent admissions into the hospital because of volume expansion. In those situations, it may make sense to start patient on dialysis for volume control so that the patient doesn't have to get admitted into the hospital frequently.
What's the highest level of creatinine clearance for uremic pericarditis that you experience?
So in my experience, uremic pericarditis is quite rare actually. Most of the time when we start dialysis, patient does not have uremic pericarditis. So again, the pericardial rub, you don't see that. The patients, again, it varies from patients to patients. Some young, healthy males or females, they have a GFR of 5 and they are asymptomatic, and you will see them in your clinic. Sometimes you will do a blood work and the creatinine will come 1,000 and GFR is 5, but you talk to the patient, they are fine because they have not had any symptoms.
It's good on a long flight though.
Say it again?
It's good on a long flight if you're going on a long flight.
You don't have to go to bathroom. Yes, that's good. But even if the GFR is low, they can still be making urine like we discussed, and we want to preserve that. Any other questions? Well, thank you so much. This was a wonderful opportunity, and I look forward if this talk was helpful, or if you would like me to modify it in any form or fashion so that it could be beneficial for your colleagues in Brampton.